Good afternoon, all. I'm Dr. Seema Deshmukh on the behalf of the Special Interest Group on Quality and Safe Use of Dental Materials, JSS Dental College and Hospital, JSS Academy of Higher Education. Welcome all the participants for the enriching clinical experience that we are going to share today with this webinar. Updates on advancements in clinical practice and patient care has always been the focus of JSS Dental College and Hospital and JSS Academy of Higher Education and Research. So, is the objective of this particular special interest group on quality and safe use of dental materials, which focuses towards advances in the field of dental materials. This group was formed with the intention of focused and dedicated activities in the areas of advances in dental materials, which includes not only the restorative materials, but also the other various materials like the ones we use for maybe endodontic care, for impression materials, for denture materials, or even those ones which are made for therapeutic purposes in periodontal cases. This particular group was formed with a vision of focused group of research and advancement in the field of dental materials by our former Dean, Dr. Nandlal, who is here with us today for the webinar. Good afternoon, sir. Presently, this particular group is multidisciplinary and unique in that we do not only have the specialists from dental fraternity, but we also have various other faculty members from pharmacy, from engineering sciences as well, who are all working focused towards the single goal. And this particular group is now being led by our ever encouraging principal, Dr. Ravindra S. Sir, he's here with us for webinar. So good afternoon, Dr. Ravindra.
Good afternoon.
Sir, I now request our principal, Dr. Ravindra S, to give the opening remarks.
Good afternoon, everyone. Thank you, Dr. Seema. It's my pleasure to welcome Dr. Spurti Anu, Professor and Head, Department of Periodontics and Implantology. She has a vast teaching and research experience, especially in regenerative materials in dentistry. I welcome you, madam. I extend warm welcome to Rani James, a senior scientist and a researcher, to this webinar. I welcome you, madam. I welcome Dr. Chandramouli, Manager, Academic and Scientific Affairs at GC India. He is a dentist, graduated from AME Dental College, Raichur, and he has 13 years of experience in GC India and been awarded budding entrepreneur in dentistry. I welcome you, sir. I also welcome Mr. Ankur Chawla, Director Sales of Traders Technology India Private Limited. I welcome you, sir. I welcome all the panelists and participants to this unique webinar, where you have an opportunity to listen to academician, researcher, and an industrial person. I once again extend my warm welcome to everyone. Thank you.
Thank you, sir. We are in the era of advancements, and dentistry is no exception. One such area in dentistry which has seen the ever advancements is the area of regenerative dentistry. This area is emerging as a promising area of education and research which aims to provide a biological alternative to the already traditionally present treatment modalities which focus towards replacement and regeneration of oral and dental tissues. Hence, to share their experiences in the field of regenerative medicine, we have with us today Dr. Spurti and Dr. Rani James. Dr. Spurti is currently heading the Department of Periodontology in Kelly Institute of Dental Sciences, Bangalore. With keen interest in the area of research like regenerative biomaterials and stem cells and implants, she has contributed immensely to the field of dentistry. She has been a researcher, she has been a resource faculty for various workshops and training programs, and she has also been an organizing secretary for CD programs, workshops, and even conferences. She has more than 35 publications in national and international journals to her credit, and she has also authored various chapters in national and international textbooks. We are indeed glad to have you with us, ma'am. Welcome, ma'am. We also have with us on the similar grounds a senior scientist from DIPON Ed Biointelligence, Bangalore, Dr. Rani Jain. She completed her PhD from Rajiv Gandhi University of Health Sciences and has worked as a scientist in various companies in Bangalore and also as an ICMR research fellow in Kidwai Memorial Institute of Oncology. She is the coordinator for fellowship in clinical regenerative medicine and has over 15 years of experience in medical writing and clinical research. We welcome you, ma'am, for today's webinar. I now request Dr. Spurti and Dr. Rani James to kindly go ahead with the webinar presentation.
Thank you.
Thank you so much, Dr. Seema. And I thank Dr. Ravindra sir also for giving me this opportunity, JSS Dental College and the whole of the staff who are involved in this program. I as well thank Dr. Kaushik and Dr. Kumar and everybody from DIPONET. They have been really supportive throughout my journey through the material which I've been using through their research facility. So I'm thankful to all of you. So without much ado, let me start off with my presentation for today. This is going to be a post-coffee session, so I hope you enjoy this session. So let me begin with this. So today I'm here to talk about the recent advancements in regenerative dentistry. I'm Dr. Spurti Belludi from Cayley's Institute of Dental Sciences, Bangalore. And it's my proud privilege to be here talking to you regarding the same. Well, talking about, one second. Yeah. So talking about regeneration, the term regeneration is an enigma by itself. So it's so difficult to just even term it or define it or even to look into it because there's a plethora of stuff that's going on in today's world of regeneration. So as we can see, there have been numerous procedures that have been investigated in the past to try to promote both soft as well as soft osseous tissue regeneration. However, the success of these approaches have been highly variable. Various approaches talking about, if you want to talk about some solution for this, then we are looking at some biological solutions for biological problem. Since regeneration is a biological problem, we would look at a biological solution. And talking about biological solutions, there have been numerous biological solutions ranging from tissue engineering, applications of biologics, cell-based techniques, biomimetic nanoscaffold fabrication, and endogenous regenerative technology. So talking about regen as a periodontist, when I want to speak about regeneration in periodontology, there has been a broad range of periodontal regenerative procedures that are available, such as your root biomodification, bone replacement grafts, membranes for guided tissue regeneration, growth factors, and last but not the least, the tissue engineering. And we need to know that, unfortunately, regeneration of periodontal tissues has been an elusive but a laudable goal. It requires the regeneration of basically three diverse tissues in that is your periodontal ligament, cementum, and alveolar bone. So talking about tissue regeneration or tissue engineering has basically evolved from the field of biomaterials development and refers to the practice of combining the three components, that is your tissue engineering triad. Now, the tissue engineering triad composes of your cells, scaffolds, and the biological factors, with the goal of tissue engineering is to assemble functional constructs that restore, maintain, or improve damaged tissues or whole organs. So one of the aspects of tissue engineering is your endogenous regenerative technology. So one of the aspects of endogenous regenerative technology focuses on incorporating these tissue engineering principles for regeneration. And endogenous regenerative technology in periodontics applies the patient's own regenerative tools. That is, the patient-derived growth factors and fibrin scaffolds, sometimes in association with commercialized products, to create basically a material niche in an injured site where the progenitor or even your stem cells, neighboring tissues can be recruited for in situ periodontal regeneration. So endogenous regeneration technology is a complex process, basically, which involves cell homing, proliferation, differentiation, which ultimately leads to regeneration of lost periodontal tissues through a natural wound healing process. In this endogenous regenerative technology, what we are looking at in today's era is majorly the platelets. The platelets play a key role in wound healing, and that is because they possess biologically active proteins like fibrin, fibronectin, and vitronectin. They bind within a developing fibrin mesh or to the extracellular matrix, thereby creating a chemotactic gradient. When this happens, there is a recruitment of the stem cells, stimulating the cell migration, differentiation, and promoting repair. So why we are looking at platelets is because they have abundant of polypeptide growth factors that are trapped in the alpha granules. Now, which are the polypeptide growth factors? They are the platelet-derived growth factors, transforming growth factor beta, insulin-like growth factor, vascular endothelial growth factor. So all of these growth factors put together allow the platelets to have a role and have an effect or a favorable effect on the periodontal regeneration. So this has basically led to the idea of using platelets as therapeutic tools to improve tissue repair as well as regeneration. Now, since quite some time, since the time when it was first classified, since then there has not been any stopping for these platelet concentrates. There have been several commercial systems and proprietary preparations that have existed that have yielded various forms of platelet concentrates, ranging from your platelet-rich plasma, platelet-rich fibrin, and even in platelet-rich fibrin also there are different cellular composition, different platelet concentrates which have growth factor recovery and kinetics of release. So looking at this, we started concentrating on platelet concentrates. At the same time, we had this information regarding platelet-rich fibrin matrix, which had a single kit that was only available in US at that point of time when I started my studies and my research on platelet concentrates. The most favorite and the most talked about and the most worked upon was the platelet-rich fibrin, that's the Shukran's platelet-rich fibrin. That was very easily done. But I wanted to do something different and explore something different, and that's why I went into checking out with the platelet-rich fibrin matrix. Platelet-rich fibrin matrix is nothing but pure platelet-rich fibrin, not the LPRF, that is the leukocyte-rich platelet-rich fibrin, which is also called as the Shukran's platelet-rich fibrin. So this is also a second generation platelet-rich concentrate, but it is a pure platelet-rich fibrin, that is, it is devoid of your leukocytes. So this was the kit which I procured from the Selfil company from USA. It costed me a bomb, and it was very difficult for me to procure and work and continue my work in this direction. We did a lot of work on this. We did a lot of studies. We did randomized controlled trials also using this. We got amazing results also. We use this material in for osseous defect regeneration. So we used to raise flaps, place the platelet-rich fibrin matrix in situ and sutured it in place. And here you can see the result at baseline, 3 months and 6 months. So this led to the idea that platelet-rich fibrin matrix gives us tremendous results. So at this point of time, I didn't stop. I wanted to check it out and compare it with the widely acclaimed platelet-rich fibrin, that's the Shukran's platelet-rich fibrin. So we went ahead and we conducted studies and we did a comparative evaluation of both mechanical properties of platelet-rich fibrin as well as platelet-rich fibrin matrix. We did a characterization using a scanning electron microscopy of both the materials and compared them. We also did the blood parametric analysis of the residual serum to find out how much of platelets are leached out into the serum rather than being incorporated into the clot. So after we did a lot of studies, we did it in the Indian Institute of Science, Bangalore, as well as we did it in Hysitron company for the mechanical testing properties in Trivandrum. And we got very good results. These are the SEM slides, which I am showing you. You can very clearly, distinctly observe that there are a lot of abundant concentration of platelets in the platelet-rich fibrin matrix slide in comparison to the platelet-rich fibrin. Also, we saw that there were more number of activated platelets in the platelet-rich fibrin matrix than compared to the platelet-rich fibrin. Activation of platelets is a very integral and an important point at this point of time I would like to mention, because until and unless the platelets are activated, we are unable to get the required growth factors that are responsible for the regeneration what we are looking at. So not just the activation, not just the concentration, even the fibrin formation, the network formation, as well as the mechanical strength was far more superior with platelet-rich fibrin matrix than compared to your platelet-rich fibrin. So this was the mechanical testing done. And this is the mechanical properties which was shown that platelet-rich fibrin matrix was more superior. As I said, we also did the platelet counts in the residual serum, and we saw that just about 2,000 cm cubic millimeters was leached out in PRFM than compared to PRF. So as I said, all this led to our conclusion that platelet-rich fibrin matrix is a very important platelet concentrate which needs to be studied, and we should go ahead with our research in this direction. At the same time, we also know that a lot of tissue engineering is happening and revolving around your mesenchymal stem cells. So mesenchymal stem cells are multipotent stromal stem cells. They have been procured from many places, from your umbilical cord. The sources could be adipose tissue and even the peripheral blood. And it's also shown that the bone marrow derived mesenchymal stem cells can differentiate into your osteoblasts, chondrocytes, adipocytes, and so on and so forth. But the problem here is it required the aspiration of bone marrow from the patient that can cause pain and morbidity of the donor sites. So it was very convenient if we could harvest peripheral blood mesenchymal stem cells, expanded it to enough numbers with their osteogenic capacity, maintained it in a clinically permitted period. So we had numerous researches and articles showing that PBMSCs, peripheral blood mesenchymal stem cells, are equally as potent and equally good as compared to your bone marrow derived mesenchymal stem cells. So as we can see, our direction towards peripheral blood mesenchymal stem cells as well as platelet-rich fibrin matrix was growing stronger and stronger. Well, despite the research, I would just like to say here that how I wish there's so much of things going on in our research of regeneration. How lucky are these lizards, that they just can just regrow whatever they want to. Or if we could do that, we can just achieve anything on top of our head and get loads of hair, which everybody is striving towards in today's generation. Well, at this point of time, I would say, yes, we do have a new kid on the block. And that is when we realized the importance and the advantages of peripheral blood mesenchymal stem cells as well as platelet-rich fibrin matrix. We thought, why not combine it and come ahead and get our new kid on the block? That would be our supercell. That is the combination of peripheral blood mesenchymal stem cells and platelet-rich fibrin matrix. So how do we go about the procurement of this Merisis supercell? So there's a kit that is provided by the DIPONET, and it's been really a pleasure meeting Dr. Kaushik, because as per our Prime Minister's message, Atmanirbharta, it's exactly like Atmanirbhar, because I could get something right within India in Bangalore, that is the platelet-rich fibrin matrix, I was helped to procure it right here. And it was very useful for me. And since then, there has not been stopping me in the research field of platelet-rich fibrin matrix, or even in the research of Merisis supercell. So how do we go about procuring this? First is we take a small amount of patient's own blood. We do a phlebotomy, withdraw around 9 ml or 8 ml of the blood into the vacutainer. The tube is then placed into a centrifuge and spun for 6 minutes at 3,400 RPM. And that's when the blood is separated. I'll show it depicted with the pictures accordingly, as well as the video. Then the red blood cells are separated, located below the cell separator gel. And above, you can see a 0.5 to 1 milliliter of stem cells, peripheral blood mesenchymal stem cells situated. Now, at this point of time, either you can use it in situations where you just need to inject it, like for instance, in any kind of facial plastic surgeries or hair regrowth, regeneration, or any other areas where you want to inject it in liquid format, you can just stop at this level. But in cases of, as a periodontist, when I'm speaking, I need to incorporate it into regenerative, that is your osseous defects. And osseous defects are not contained, so they can't contain any liquid product. So we need a gel product to be placed in situ. So at this point of time, we can utilize the liquid stem cells incorporated into forming into the platelet-rich fibrin matrix to form a clot or a gel, which can be easily manipulated and placed in situ. So again, what we do is we again withdraw by your regular standard phlebotomy 8 ml of whole blood, take it into the vacutainer, and mix the 0.5 to 1 ml of the peripheral blood mesenchymal stem cells, what you have got, the mononuclear stem cells, into this and centrifuge it for 5 minutes at 3,400 RPM. And when you do that, there is a polymerization that takes place and allows for the formation of something called as a supercell. So at this point of time, I would like to say that how do we know that there was, stem cells present? So at the DiPoNet, they did a flow cytometric analysis and they checked for the CD45 and CD105. These are the stem cell markers. And they saw that there was abundant of these stem cell markers which are present. So they used they analyzed it with the two dyes, that is your phycoerythrin as well as the fluorescein isothiocyanate. And with this help, you could clearly see the spots, the red spots in the graph showing the stem cell markers, showing that there was a presence of stem cells in this 0.5 to 1 ml of liquid which we had procured. So this is the Merisis supercell kit, what we are seeing here. There are two tubes. That is the tube on the right side, that is the one which you can procure PRFM. And on the left side, that is the blue one, is your supercell or your stem cell tube. So with this, what do we do? As I previously said, we procure the blood through the phlebotomy procedure. We place it into the centrifugal machine for 6 minutes for 3000 RPM in the MIRHC machine with a swing bucketed rotor. And here you can distinctly see the layers. That is, upper layer is the plasma layer. The lowermost layer just above the gel barrier is your stem cells. That is around your 0.5 to 1 ml of stem cells. And lastly, you have the formed elements of your red blood cells. Now we go ahead, take the syringe and we extirpate and remove the above plasma poor layer and discard it. And later on, we aspirate the stem cells which is present at the bottom just above the gel barrier. So once we do that, we take again another 8 ml of the blood. We mix the peripheral blood mesenchymal stem cells to this tube, slightly shake it, again centrifuge it for 3,400 RPM for 5 minutes, and lo, here you have the Merisis supercell. That is a wonderful combination of your stem cells as well as platelet-rich fibrin matrix. So this is how it looks like. And then onwards, we can use this in any kind of case of starting from your endodontic problems, even your regeneration, any kind of endoperio lesions, or even in implants, dental implants, or also you can use it in the periodontal defects also. So there's a wide range, a plethora of clinical scenarios where you can use this regenerative material. So this is a video which I would like to run through, which will exactly show you how you have to go about procuring the stem cells and the platelet-rich fibrin matrix, that is your supercell. So this is the preparation. It's the part 1. So we do the phlebotomy procedure and we withdraw 9 ml of peripheral blood. And once the blood is withdrawn, the blood is transferred into the vial or the tube. This is the Merisis supercell gel separator tube for the preparation of your supercell. With all the aseptic precautions, we transfer the 9 ml of blood that's been collected through the phlebotomy procedure into the cell separating tube. Once that is done, you just give a slight mix 2 to 3 times so that the blood mixes. Then we place the Merisis supercell tube and we balance it with a blank tube, either with a saline or water on the opposite side. Balancing is very important at this point of time. So using the REMI R8C swing bucket rotor centrifugal machine, we centrifuge it at 3000 RPM for 5 minutes. We can do it for 6 minutes also. Sometimes I do it for 6 minutes. So after doing that, you remove the separator tube from the centrifuge. You can clearly see the straw colored material which is present on the gel barrier, and the lowermost part is what is our supercell layer. That's the 0.5 to 1 ml of the solution. So what you do is you aspirate the plasma poor cell layer above, and the lowermost 0.5 to 1 ml of the supercell is left behind, and then it is inverted a couple of times so that it just mixes evenly with the rest of the plasma. Then you carefully collect this 0.5 to 1 ml of the plasma containing the supercell, aspirate it into another tube, and keep it aside for the further use. Or you can use it at this very point of time if in case you can inject it in some places. I have used it as an injectable instead of injectable PRF, and it has given me very good results. So you transfer and keep this aside if in case you cannot use it at this point of time in a liquid format. So the next is the second stage. That's your part 2. That's the preparation of glue. This is very integral for me because I need to do this. Without this, I cannot place it in most of my patients. So we draw around 9 ml of the peripheral blood, or even 8 ml would suffice, because you already have 0.5 to 1 ml of your supercell. So this is the kit for the gel separator tube for the preparation of your platelet-rich fibrin matrix. So this has made my job really easy because I had to rely on the US product, which was very cumbersome to get it, and it used to be very difficult for me to procure. It costed me a huge amount also. So this suits me. So again, we do the same procedure. We go ahead, do the phlebotomy procedure, draw 9 ml or 8 ml of blood, transfer the amount of blood into this tube. And once we transfer, you take the supercell which you had kept aside, mix it with this tube. This is how you need to mix it. And you can have a balancing tube as well. Balancing is very important. Mix the tube evenly. You don't need to mix the balancing tube, which is being shown here. It's just that maybe it's like a dance step the person is doing for both the tubes. You just have to mix it for the supercell and platelet-rich fibrin tube. That's enough. And then again, you centrifuge it in the same centrifugal machine for 3400 RPM for 5 minutes. So once that is done, you remove the tube. You have the gel, that is the supercell. So you can carefully remove it with a long beaked tweezer, or any instrument which is it's convenient for you to remove, and you can place it in a sterile glass tapping dish, or also you can place it on a gauze strip. And we work in periodontics. We try to make a membrane of this. So I sometimes use 2 gauze strips to squeeze in the serum and make it into a membrane. I use it as a guided tissue regenerative membrane also. So this is how it worked. So that was your supercell preparation, which is thanks to Diponet we have that. So the literature search till date do not show any human clinical trial conducted to assess this regenerative potential of this new modality, that is your platelet-rich fibrin matrix and peripheral blood mesenchymal stem cells. So hence, we are evaluating the supercell as a potential regenerative material for various clinical scenarios. And I have almost used it in every clinical scenario. We have even done lots of research work, randomized control trials using the dental implants, and also being used in regenerative procedures, also in your osseous defects. So we have randomized control trials going up to that. Also, I have again gone ahead and taken the help of IISc and done my scanning electron microscopy and compared it with all the platelet concentrates. Even the mechanical properties also have compared it with all platelet concentrates. We have around 7 to 8 platelet concentrates in today's research world. So I've compared it with all of them, and even the as I previously said, I have also seen the leaching out of platelets, how much of leaching out of platelets takes place into the serum. So even that I have compared with all the platelet concentrates. All of this is in line for publication and is being reviewed in various publication forms. So I'm sure I'll be coming out with new ones. As of till date, this is one of my first publications, which is a case report where I've used supercell for the class 2 management of class 2 gingival recession, and which has come out really well. I'll be showing a couple of those cases. I'll just quickly run through because I don't know who. I'll just quickly run through all those cases. So this is a periodontal intrabony defect. This is how a defect looks like. We procure the supercell, place it in situ, suture the flap, and 4 months post-operative, we get very less periodontal pocket probing depth. And you can see the bone regeneration that has taken place after 4 months post-operative. This is another intrabony defect wherein we have used the supercell, again placed it in the defect side and sutured it, and you can clearly appreciate the amount of regeneration that has taken place in the intrabony area. So this has been really good for me. So as I said previously, we have had a publication. This was the first publication for supercell in periodontal regeneration in root coverage procedure. This was the case which got published recently. So here we can see this is the kind of recession what we are seeing. We raised a coronally advanced flap, placed the supercell in situ, raised the flap coronally, sutured it, and this is the beautiful result what we are achieving. Most of the recession is covered. And this is another endodontic lesion wherein we went ahead, did the endodontic root canal treatment. And once the treatment was done, we raised the flap, placed both supercell as well as bone graft, and saw for the results and looked out for the results. And this is the kind of result what we are achieving both in the furcation region as well as in the osseous defect region. I'm not elaborating this because I'm not sure what kind of crowd is watching this. So I'm just quickly running through my slides to show the kind of the impact or the kind of results and the outcomes I have achieved using this material. So this is a wonderful surgical procedure, an endoperio procedure. The endodontic department people came ahead and gave us this case and told us what can we do. So it was a huge fenestration defect, and I opened a flap, very technique sensitive flap with full partial thickness flap, and this huge defect was filled with supercell and sutured. And once that was done, this is a 10 days post-operative healing. You can also appreciate how the post-operative healing has taken place from 1 month to 3 months to 6 months, and last but not the least, the 2 years post-operative healing. Even in the radiographs, you can appreciate from pre-op to 3 months to 6 months to 24 months. And from there on, you can clearly see the difference between the pre-op picture to your post-operative, how beautifully it has healed. It's been phenomenal. The patient had recently come, and the patient is happy, I'm happy. This is another regenerative apicectomy procedure. Apicectomy was done, root canal treatment was done. We placed the supercell in situ, and we also placed a membrane because we thought that we wanted to, do permutation and combinations with different regenerative materials. Once maybe a bone graft, once the GTR membrane. So this also gave us very good results. This is another place where there's a socket preservation technique where we extracted the tooth atraumatically, placed the supercell for the regeneration of bone in situ, and temporary restoration was given, and this is how the bone had regenerated in place. So this is a case where a dental implant was placed, and post-implant placement, we placed the supercell, put a GTR membrane because labially there was no much of bone and the implant was exposed. So we did this, and the implant very beautifully took up and got regenerated. The patient is in US as of now because of maybe COVID. We don't have any news of the patient. No news is good news. So this is another case where the patient had a periapical granuloma. Atraumatically, we extracted it. We curated out the region, removed and irrigated the region for any kind of lingering infection, placed the implant, and in the jumping distance around the implant, we placed the supercell and sutured it, beautifully integrated. So with this, I would like to also say that we conducted almost a 60 case implant randomized control trial involving 60 cases, where we placed the implants on one side, we placed platelet-rich fibrin matrix, and on the other side, we placed supercell, and we checked for the implant stability, bone to implant contact, and so on and so forth. And we got very good results with both of them, and especially with supercell. So this is another socket preservation technique where we use supercell and we regenerated bone again. And this is how it went about. And later on, once the bone was regenerated, we placed an implant. And this is a ridge augmentation case. One of the prosto people had opened up and they saw that there was a huge defect. They called in me for the regeneration of this area. So we went ahead and placed the implant in the distal aspect. Anteriorly, there was no bone. So went ahead, placed supercell, placed GTR membrane, sutured it. And people keep asking, how do you account for a true regeneration? And I will say, just reopening and re-looking at it. Even histological section also shows whether there is true regeneration, but reopening the region is also one of the ways to confirm that there has been truly regeneration that has taken place. So this cannot be a simple bone fill. This is purely bone regeneration. So after that, it was almost time tested because we also went ahead and placed an implant in situ. And once the implant was placed, this is how the preoperative radiographs and the clinical pictures were seen. You can see even after 2 years, the implant is doing really well in the regenerated area where the supercell was used. So as I said, we did a randomized control trial wherein we use 60 implants. We put PRFM on one side and the supercell on the other side. So we went ahead and checked for the ISQ readings with the resonance frequency analyzer. And we saw that not just the initial stability, even later on also the stability was much higher. It was more than nearing 89 to 90%, 90 value which was seen even in the second stage of healing also. This shows that bone to implant contact, which is the most important and integral part of any kind of stability that is anticipated for any implant, was also very good when we use this material. So these are a couple of cases, and I already said there are numerous platelet concentrates. So we have compared platelet-rich fibrin matrix or supercell with all these different platelet concentrates, both characterizing it by a SEM analysis, as well as we did blood parametric analysis. In all those, the supercell or platelet-rich fibrin matrix truly emerged as a winner. So at this point of time, I would just like to say, we can't all be Rajnikant, but maybe we are at the point where we can regenerate anything and everything, and mind it, difficult is not impossible. Thank you so much. And these are my references. And last but not the least, I would like to thank the my staff and postgraduates of Department of Periodontics, our principal, Dr. Srivatsa Ji. I'd like to thank Mr. Rajsekharan, Dr. Raji from Indian Institute of Science, and last but not the least, our guru, Dr. Ramanand Nade, and the person who saved me from all the problems, that is Dr. Kaushik Dev. I was fortunate to meet him, and everybody, including Dr. Kumar, Dr. Rani, and all the scientists at staff at DiPoNet. I'm very thankful and grateful to them. Thank you so much.
Thank you, Purti. This is Dr. Nandalal here. So thank you very much for the wonderful, I would say, creation along with DiPoNet. And as I also like to thank Dr. Kaushik, which he and his team, Dr. Samarstha and Dr. Muralidharan, who is also known to us. Dr. Muralidharan has been I'm just taking the time before the slide share goes to Dr. Rani. Sumuk, can you please go ahead changing the slide share to Dr. Rani? And also, Dr. Muralidharan was the person who came to JSS and said that we can do something together. And by the time we could plan, it's COVID war. And anyhow, we are still meeting, and I'm sure it was wonderful. This is what I was expecting, that it is the use of this supercell and that too made in India methodology, and would we make it easier for everybody to put in practice and make it economic as well compared to what the challenges which you said. And also we are sure that its application is not just in periodontics, it goes to, of course, surgery, which is well known as well. But now you opened up another very good endodontic challenges which can be met. I'm sure many endodontists are watching. The numbers registered were very they are just hopping in and out, some of them. But the large number of participants are there. Most of them are even periodontists, endodontists. I'm a pediatric dentist. So regeneration is the word today, and especially in implant, I think it does wonders, because there also they need a good crystal bone height, and I'm sure you would have found that compared to the normal healing, that would be there. So thank you once again from JSS Academy of Higher Education and JSS Dental College and Hospital, SIG, that special interest group of safe and quality and safe dental material. Thank you
so
again.
much, sir. Thank you.
Over to Dr. Rani. Welcome, Dr. Rani.
Thank you, Dr. Nandalal. And thank you, Dr. Seema, for a nice introduction. And thank you, Dr. Ravindra, for a welcome speech. And I thank Dr. Kaushik for giving me this opportunity. So today I'm going to talk about our DiPoNet Institute of Regenerative Medicine. So I'm going to share my screen. Okay, now. So today I'm talking about the two courses. One is Fellowship in Regenerative Clinical Medicine, and the another one is Certification in Regenerative Clinical Medicine. So I am Rani James. I'm working as Senior Scientist at DiPoNet Biointelligence, and I am also the Scientific Course Coordinator of the Diploma in Regenerative Medicine program. So now we are conducting two online courses. One is the Fellowship in Regenerative Clinical Medicine and the Certification in Regenerative Medicine. So I am going to talk about these two courses. So DiPoNet is an innovative healthcare biotech company, but we are not only focusing entirely on research, but we are also work to create awareness on latest healthcare trends through our online education program. So in this venture, we join hands with Datta Mega Institute of Medical Sciences in Varda, and Dr. Sandeep Srivastava is the course coordinator from Datta Mega Medical Institute of Sciences. And the course mainly focus on stem cell biology and regenerative medicine. So here the students got the opportunity to learn about stem cell applications. So mainly it focuses on regenerative medicine. So in simple words, if you say regenerative medicine, it is the healing within. Okay. So here we are dealing with the process of how the cells work, how the cells are replacing and the regenerating human or animal cells. So the course is open to qualified doctors, surgeons, physicians holding a degree in medicine, and even for life science graduates who is holding a degree or MSc in biology, biochemistry, or related fields. So the course mainly introduces all the aspects of regenerative medicine. Regenerative medicine seeks to devise the new therapies for patients with severe injuries or chronic diseases in which the body's own response do not suffice to restore functional tissue. As we have seen in Dr. Spurti's presentation, so it is a part of the regenerative medicine, how the stem cell work. Dr. Spurti has spoken about periodontal application. So in the course, we are covering about various applications of the stem cells mainly. So the course is structured. It is mainly on online platform, and now it is very suitable now because everyone is sitting at home, and we can. So in the meantime, you can do a very useful course. And here the course are structured at weekly sharing of study material. And we have created a WhatsApp group so that the students can interact directly with the faculty and they can clear any doubts if they have. And also each module, after each module, there will be examination and there is a multiple choice questions and there is quiz also. So now coming to the faculty, so we have very good faculty from around the world. One is Dr. Sandeep Srivastava and Dr. Deepak Puri and Dr. Spurti and Dr. Kalpana, and from our DIPON, from Dr. Sharmishta, me, myself, and Dr. Kaushik and Dr. Vanida. These are the faculties. So let me give a quick introduction about the course overview. So first I'm going to talk about the certification in regenerative medicine. It is a 6-month course. And after that, I will quickly go through the fellowship in regenerative clinical medicine. It is a 9-month course. So the eligibility, it is open to all the Indian and NRI citizens. And whoever the qualification, whoever has a qualification in medicine and life science are eligible. So the first one is a certification in regenerative medicine. It is a 6-month course. So the course, you can see the course overview, and the first 2 months we will deal about how first we will introduce, before going to the regenerative medicine, first we will begin with the basics of the course, how the cell work and what is the structure and how the cell functions. So after you get a thorough understanding of how a cell behaves and its functions, we will go to the next section, that is how the cell can be expanded in a cell culture lab. So here we will give a detailed information how the cell can be isolated and expanded. And since we are working in the wet lab, we know the practical, not only from the book, we know the practical aspects, what all issues we are dealing when we are expanding the cells. So all this knowledge we can share with our students. So after we learn how the stem cell, suppose if you are telling that it is a mesenchymal stem cell or it is a hematopoietic stem cells, you will come to know how we are creating, how we are isolating and expanding all these cells in the lab before coming to the doctors. So then the next month, the 4th month, we will focus on the current therapies and future direction of regenerative medicine. So in the last 5 and 6 months, we will discuss about the demonstration of cellular. Okay, we will discuss about the main aspects, that is the current applications. How this, if we are, suppose if we are giving a mesenchymal stem cell from our lab to a doctor or to a clinic, what is the application of it? What is application of platelet-rich plasma? All these things we will cover in detail in the last 5 and 6 months, and the exams will be conducted at the end of each section. So same thing only here. And the next one is the fellowship in regenerative clinical medicine, FRCM. It is a 9-month course. The main difference between the certification course and the fellowship course is that here we are including the practicals, not only the theory. You will get an opportunity, hands-on training, like you know how the stem cell lab work, how a class 10,000 lab look, and you will get a hands-on experience how to isolate stem cells and even the application of stem cells. We have a panel of expert doctors, and you will get the opportunity to learn directly from them. So almost the course is same, like first 4 months, like certification regenerative medicine, and in the last 4 months, another first extra is that you will learn more about the practical aspects, how the GLP and how the things are produced in, how the cells are produced under GLP conditions, and uh, and its application. So these are the hands-on training. What you are going to learn in the you will get a hands-on experience about all these things. That's as aseptic technique of cell culture, how the isolation of mononuclear cells, and the characterization of stem cells using flow cytometry, and how you can isolate the platelet-rich plasma, and how you can prepare the platelet-rich fibrin matrix and its application. So these are the applications. Sorry, these are the practical experience you will get if you registered in the FRCM course. And the online communication, every week the faculty will send the material, the study material, like as of videos and even as PDF or the papers and even as PowerPoint presentation. Every week we are sending it to our students, and we can the trainees can contact directly, and every month we will create a WebEx meeting or team meeting, so that uh, the students can directly interact with the faculties. Okay, same thing. So the training, all the courses are designed by the academics and lecturers from Datta Mega University also, and also from Daipanudi Institute of Regenerative Medicine. So once the participants, after completing the exams, after successfully finished all the courses, they will be getting a certificate. So this is the model certificate. So this is the course overview. And if you have any questions, kindly.
Yeah, thank you, Dr. Rani James.
Thank you.
Very nice to know that there are this type of training programs have been organized and arranged. I'm sure
Okay.
many of the participants would contact. I will share the contact number and email to them, and through, I think Murlidhar has shared with me.
Yes, yes.
I will do that, and definitely I'm sure that this type of a training will be the future, and people may also look for research as one of the options, and get into, of course, clinical management as well as research could go hand in hand. Thank you once again on behalf of GSS Academy of Higher Education, and taking out time to join us in this SIG Special Interest Group webinar series. Thank you, Dr. Rani.
Okay, thank you, Dr. Nandala. Okay.
So now I think we have overlapped with the next speaker, which is much more awaited to know. Like, as a dentist, we are worried about aerosols and air atmosphere. And I welcome the next speaker, Ankur ji, from who's going to give us some insight about how to have fresh air breath in our setting. It may be clinical setting, it may be a home setting, whether it's a dentistry or medical, or so. I'm sure because we are still to understand this. So, Mo, can you see that Ankur is coming on the screen? Ankurji, he has to unmute himself, and Haji, hello there. Well, so that's that's Dr. Chandramouli has come over. I think Ankurji is on. He's going to start his.
Yeah, he's on board, sir. He'll be speaking now. Yeah.
You can just allow him to share the screen. Meanwhile, again, I would say there is always a debate. I'm sure Ankurji will tell us where do we keep the air purifiers, and how, which locations, and what should be the height, where should be all these challenges. Like, there has been a thought that we need to keep some revolving or oscillating fan behind the chair against the patient, so that against the operator and patient, so that the ventilation side, the air moves. And similarly, this air purifier, like, of course, I was also been looking at this from the last 2-3 months. If we need to practice, what are the locations we keep? What should be the height? Where should we? And are we looking at very nearby, or it need not be nearby? Like the fan is nearby the location, but I personally felt that it can be away, because we need to, in the end of the day, what is around should get purified, and whatever the system mechanics, and there are so many mechanics and technologies, each one claiming a different plexus, like filtration systems. Like it starts from a simple HEPA filter to going to the UV level and a plasma. So then I'm sure that all of us have these questions, what we need to do, and if at all we have to build up this system in our day-to-day dental practice. Ankurji?
Yes, sir.
Ankurji is there?
Yes, sir.
Yeah, please take over, please.
Okay.
Yeah.
Yeah.
We welcome you on behalf of JSS Academy of Fire Education.
Sure, sir. Thank you. Thank you so much.
Yeah, safe practice dental settings. Yeah.
Just give me 1 minute.
Sure, sure. I normally prefer that I would also need, if at all, air purifier. It is just, I don't know, it's just a satisfaction or a need, but I would like to keep where the doctor's resting area as well. Of course, the question was whether we should keep near the patient and operator.
Sure, sir. I'll definitely answer that.
Yeah. So these are all the challenges and questions everybody has in mind. But yes, it's an expensive affair. We cannot say that we can have in multiple locations in the same place. But let us see. Let's hear from you. Thank you.
Thank you, sir.
Our next speaker is also already, we are overlapped. We may speed up a little bit. I know it was very kind of you to have accepted to come, because many of them, like to hear things so that they can come and decide what they can.
Right. So I'll just begin with a small slide about the product and regarding the questions that Dr. Nandlal raised about where to position the product. So just like to introduce myself. My name is Ankur Chavla. I am director from the Crusaders Air Purifier Company. And we've been in the business of air purification since 2004. And we make majorly the standalone products. So this is a little bit about the company that we are in the business since 2004, and we are making a product which is designed as per the Indian specifications or the Indian requirements. We have presence almost all over India, and coming to the point where it concerns the clinics and the hospitals. So there are various causes of infection. COVID-19 is definitely a big concern now. But even prior to COVID-19, we had a lot of installations in hospitals, because hospitals clinics require a certain level of air purification, because there are various points of, contamination. And I mean, the staff as well as the doctors, everybody's health is also immediately at risk, and so is the concern for the patients who are coming in. The patients who are not infected, they are coming in. So regarding where we can position the product, as you can see in this image, that the product has been positioned right behind the chair, the dental chair. So basically the concept is that the product should be within about 3 meters of, within about 3 feet from the point of aerosol release. So if the person who is sitting on the chair, the patient, the machine should be within 3 feet from the point of aerosol release of aerosols. So in this application, as well as in this image over here, you can see that the machine is placed pretty much near to the chair, within about 3 feet distance. So I'll just brief you a bit about our technology, because there's a lot of understanding that there are HEPA filter. The guideline says that you have to have a HEPA filter, HEPA 14 grade filter, and it doesn't mention anything else. So I will just take a small little time and stress upon the technology part of the product, about at least what we are doing in our product. So if you can see this diagram, the image, so we are using a multi-stage purification system which focuses on UV and the photocatalyst filter, the TiO2 photocatalyst oxidation filter. This helps the HEPA filter to eliminate the bacteria and the virus, because HEPA filter by definition is just a trap. It has got no effect to eliminate or kill or inactivate the DNA of the virus or the bacteria. It is just a trap, and it is not having any killing effect. So what we do with our machine is that we are using ultraviolet as well as photocatalytic oxidation filter. So what does this TiO2 filter do? I will explain you through some basic understanding. So once the UV tube is on, this plate, the TiO2 photocatalytic plate, gets charged. It gets charged with OH radicals. So OH radicals are created on this plate. And because the air is coming in and it is positioned right behind the HEPA filter, so this filter is your oxidizing filter. So it kills the pathogens, and it also takes care of all the gases in the air. So formaldehyde gas, it could be any kind of NOx gas or a sulfur compound getting created inside your room. So majorly, I mean, any VOCs, I can say, any volatile organic compounds, this particular filter will handle that, as well as it will handle the pathogens. So this is a very important filtration, which is even in normal circumstances not used by major companies, and they're all depending on the same HEPA filter. So HEPA filter we are also using, it's a 14 grade filter in our machine also, but we don't depend only on the HEPA filter. So after this, then there is a negative ion technology that we are again releasing ions in the air. I can share certain documents with you, and those documents are related to ionization. I can share those links with people in the chat box, and you can read through them, that how negative ions also help in taking care of, again, the airborne viruses, airborne pathogens. So this is again a very important part of the purification system. And this is the killing aspect and the HEPA 14. Then we have the carbon filter and the pre-filter to basically take care of the so this is a little bit about the ionization. Ionization is also directly related to your immunity. The concept of ions is basically similar to what you feel as a freshness when you go to a hill station, or when you go to a higher altitude, or even beaches, waterfalls. So you get a fresh feeling, right? You get the feeling of fresh air. So even in older generations, the concept was very clear. If you're not feeling well, go to a hill station, go to some place wherein you can get fresh air and you can get self-recovery from diseases. So here there is a chart which is by WebMD. It clearly shows that if the ion concentration in your room indoors is less than 50 ions per cubic centimeter, it induces physiological impediment. And if the ion concentration is 1 lakh to 5 lakh ions per cubic centimeter, it causes or it affects your recovery and has a self-recovery effect from diseases. Where do you get this? You get this in the waterfall or the forest area. So this is again an age-old concept which has been propagated by almost everyone, and this again is a proof. So this chart is again from the WebMD website. Also, there are certain models that we have, different models. So this is a more rectangular shaped model. It has a 180-degree suction. All our models have the same filtration technology. What is more important is that you need to concern with the airflow rate. Over here, if you see airflow rate 220 cubic meter per hour for this model. So airflow rate or the clean air delivery rate is what will create the air changes per hour. Area is immaterial. I mean, if I say that my machine can cover 1000 square feet or 400 square feet, that is absolutely immaterial, because in your space, how many air changes can my machine do will depend on the airflow rate. And basis on the air changes per hour, you have to take a call, because medically or clinically it is prescribed that you should have at least 6 air changes per hour. So that is the mandate given by the guidelines, the hospital guidelines by DGHS. So 6 to 12, it is between 6 to 12. The higher it is, the better it is. So 6 is the minimum. So again, depending on your work area, your workstation area, the closed chamber where you're working, what size of chamber it is, what volume it is, we will have to calculate the air changes per hour. So air changes per hour will always be subjective from one clinic to another. So again, this is a higher model, and this is having 300 cubic meter per hour. After this, we have this particular model, which is about 750 cubic meter per hour. And then we have this one model, which is a tower model, which is self-revolving. It revolves about 60 degrees on its axis, and it can create a circulation of air by itself. It doesn't need any external fan or air conditioning to aid the airflow faster. This is having 1100 cubic meter per hour. We are also having masks. We also develop masks, which are washable grade masks with N99 layer filter, as well as carbon filter, and 4 layers of polypropylene. So we developed this product, which is having a zip, as you can see over here, and the filter is a separate part of the product. So you can remove the filter, and the main mask can be washed whenever it gets dirty, and you can keep changing the filter. And the mask has a life of approximately 2+ years, because it's a cotton cloth mask. So general wear and tear is based on your washing techniques only. So if you just hand wash it and wash it with care, you can easily take the product's life to about 3 years also. So these are certain clients that we have served over the period of 16 years in the air purification industry. We have done a lot of hospitals, we have done a lot of embassies, government institutions, corporates, and these are certain customer references, reviews, both from private individuals as well as government offices. And we serve the customers with service, AMC, after sales as well. And these are the basics about our company. We can take care of pathogens, we can take care of VOCs, we can take care of positive charges in the air, static in the air. So all of that can be handled with just one device, because of the 6 filters that we're using inside this machine. So if any questions are there, sir, I am ready to answer them.
Yeah, just you had told that was one of the problems, like, whether we should wash or clean that the first layer, the blue, and what was the blue layer you call that?
Pre-filter, sir.
Pre-filter, yeah.
This is, this is for about 10 micron size of particle. You can do it once in a month.
Once in a month, okay. And
that's good enough.
Yeah, thank you for that. And then one more thing is like if at all now, because though you said the pathogens are getting killed inside,
Right.
but like somebody says no, let us keep it in the sun. Should we do
Yeah,
that?
no, you should. I mean, see, why I would say that is because the carbon gets regenerated once you keep it in the heat. So if you give it good sunlight, the carbon gets regenerated. Carbon is basically absorbing all the things, and it is getting swelled up. So if you keep it in the sunlight, or if you keep it in the heat, or blow hot air on it, what happens is it helps in evaporation of those gases in the air, and the carbon gets regenerated to some extent. Although you will have to change the entire filter, this entire filter will have to be changed after a period of 3000 hours. So approximate life of the filter is about 3000 using hours of the machine. You'll have to change that. But yes, every month once you can dry clean the filter, you can clean the pre-filter, and you can keep it in the sunlight for about 2 hours or something like that, just to help it regenerate and last longer. That's a good advice if somebody has given that to you.
Yeah. So I think this was quite informative. I think you will get more calls by today.
No problem. Thank you so much. Thank you for the opportunity. And any questions, I will share a few links related to how our product has the technology to handle most of the problems that dentists are facing. I will share that in the chat box. If anybody has any queries, they can contact me on my phone. I will leave my phone number as well. So anyone has any queries, please get back to us.
So again, I thank Ankur on behalf of JSS Academy of Higher Education and Research. Thank you for taking out time. I know right now it's a real time you got back to think your work setup, and then you still find time to come and give information to share across the country. Many people around within this state and neighboring states are listening, and I'm sure they'll have some clarity, because still many have still trying to hunt what to do, whether to get one or which one to get. The number of varieties so much, and thank you for your inputs. Thank you very much, Ankur.
Thank you, sir. Thank you so much.
Dr. Seema, I think
Yes, sir. Yes, sir.
you can welcome formally our next speaker,
Yes.
Dr. Chandramouli. I think he's already there. You can, Sumo, can you let him share the slideshow?
Sure, sir. Yeah.
And Dr. Seema, please introduce our next speaker. I think I'm sorry for the delay, but I think we have 15 minutes up. Formally, Dr. Seema, please.
So after a mind-boggling session on regenerative dentistry and then on air purification, we are moving ahead further for the next part of the webinar, which focuses on the clinical modifications that can minimize the risk of COVID-19 transmission in dental practice. We are going to have an insight on how effectively and efficiently restorative care can be provided to the patients by minimizing or maybe even by replacing the aerosol generating procedures. So for this, we have with us Dr. Chandramouli. He is graduated from Raichur and he is currently working as a manager, academic and scientific affairs at GC India. Specially trained and certified in aesthetic restorative dentistry and fiber reinforcement from GC Europe training campus. He has conducted more than 100 lectures, training workshops on anterior aesthetic restorations, fiber reinforcements, post-endodontic restorations, and many more to list. He has been awarded as the budding entrepreneur in dentistry by Business Network International. We are glad to have you with us, sir. I welcome you for today's session, and I kindly request you to go ahead with the session.
Thanks a lot. Hope I'm audible and visible. Thank you very much. Very good afternoon, good evening to all. Hope everyone is having a safe time, I would say, in this gravid situation which we all are in. So as we all know that we are going through a lot of tough time with this COVID situation going around. but the question is, can we leave our essential practice and stay home? How long can we leave our essential practice and stay home? See, there are a lot of people saying it, yes, we can't leave. A lot of people say, no, we have to start a practice. So there are a lot of things going on. But the matter of thought that struck me is, if we are starting a practice, so as many of might have done already started the practice. So what are the essentials in our dental practice during this COVID situations? What are the things we can practice? What are the things we have to practice? And what are the things we have to do during this? So I thought I'll deal with one such aspect today, one of the vital essentials which can be a part of our COVID dentistry. That means the dentistry which we are doing now in this COVID situation. So, as you all know that there has been guidelines from the Ministry of Health as well as the DCI, which states that as much as possible, we have to avoid aerosol producing procedures. So, we see, I'm not going to talk about modifications we're going to do on in our clinic related to the procedures we do. Yeah, I'm going to talk about one aspect where we can do a non-aerosol producing procedure. So the need of the hour today is the aerosol free dentistry. So what are the things we can do with aerosol free dentistry in respective aspects is what I'm going to talk about today. So as we all know that with the aerosol free dentistry, there are a lot of procedures which we do with aerosol, which does not require aerosols, especially in the restorative dentistry. So today I'm going to take you back to a 3-decade-old procedure, which started off in somewhere in 1980s and 90s, which became the basics of our restorative dentistry, which I'm going to take you back to the basics, a bit of basics, which is nothing but art dentistry, that is atraumatic restorative dentistry. And atraumatic restorative dentistry is something which follows a philosophy of minimal invasive or minimal intervention dentistry. So there are in minimal intervention dentistry, you can see there is a lot of factors, like you have identify, prevent, restore, etc. So we're going to talk about the restore aspect of minimal invasive dentistry, which is basically a 3-old technique. So when you go into the minimal intervention dentistry, the restore aspect, there are a lot of things which are there in the restore division of minimal intervention dentistry. So like the air abrasions, etc. The most important thing which was developed 3 decades back was atraumatic restorative treatment. So if you see this, say it only uses hand instruments, it uses adhesive materials, it uses sealants, etc. It doesn't use anything other than that. So no dental equipments are basically required, no major equipments are required in this type of restorative therapy. So what is basically art? If you see the definitions of art, which when it started off in the mid 1980s and 1990s, when Franken also started mentioning it. So there was a lot of confusion about, later on there was a lot of confusion about the definitions of what art therapy is all about. Now, then Franken came out with a new definition, with a new aspect of art dentistry, which basically is nothing but a minimal invasive procedure to prevent dental caries lesion and to stop its further progression. So it involved 2 components. First component was art sealants. Previously, it was only art restorations. You used to do excavate, you just do atraumatic restorative treatment. Then Franken added 2 components to it. The first component was art sealant, which is basically to seal the caries prone pits and fissures. And the next one was art restorations, which is to restore the cavitated dental lesions with sealant or with restorative materials. So if you see art sealant, it is basically to place a high viscosity glass enoma, a high fluoride drilling high viscosity glass enoma, which is pushed into the pits and fissures, and it is pressed with a finger pressure. It is also called as a finger pressure technique. Then what was art restoration is, art restoration involved the removal of the soft and soft caries and completely demineralized caries tooth tissue with hand instruments, and then restoring it with an adhesive high viscosity glass ionomer again. So these two became the main components of art. So if you see, if I want to make what is atraumatic restorative treatment as a simple way, if I want to keep it simple, I can call it as the principles of art will be removal of caries with hand instruments and restoring it with high viscosity glass enemas. That's it. This is what is the principle behind atraumatic restorative therapy. So atraumatic restorative therapy is an evidence-based approach, a minimal invasive approach, because there are a lot of evidences which have proven that the atraumatic restorative therapy has been a successful therapy in terms of restoring a tooth. Last but not the least, it's a non-aerosol generating technique. You're not using any kind of aerotors, any kind of rotary instruments here. You're just using hand instruments to excavate and just to restore it with glass ionomers. Now, if you see a bit of history behind atraumatic restorative therapy, let's dwell upon certain aspects of history here. It started in 1980s, in mid 1980s. In Tanzania, it was developed in order to provide the therapy in where there was no electricity involved, there was nothing, all those kind of thing involved, in a low economic region kind of stuff. It started in mid 80s, and in 1990, WHO started accepting this as one of the major treatment therapy for the dentistry. So what it did is it started a research which initiated the development, which was actively participated with some companies like GC, and they actively participated in developing a restorative and preventive sealants, which is helpful in atraumatic restorative therapy. And this GC became the first active participant in developing this high viscosity GIC and called it as Fuji 9, which correlates with the 9 steps of art technique. So in 1994, in one of the WHO one of the World Health Day, WHO accepted art as a regular therapy, and it was introduced in clinical practice. Later on, in 2002, even the FDI accepted art as one of the restorative therapies. And of late, so in recent times, there have been modifications in art in terms of, and it is being called a smart. There are two to smart in this. One is silver modified art technique, and another is the simplified and modified art. So this is a little bit of history of art. So let's see what all are required in the atraumatic restorative therapy. What are the essentials? What are the major armamentarium which are used in atraumatic restorative therapy? So the first thing which is required is the instruments, the hand instruments. So what are the various hand instruments you require for in this kind of therapy? First is mouth mirror probe and tweezer. Of course, we need the PMT set. Then we require an enamel hatchet to gain access. Another instrument to gain access into the cavity is an enamel access cutter. Next, which we require is excavators, both small and large excavators, in order to excavate the decay off. Then we require a plastic filling instrument to restore the cavity, and of course again spatula to mix up the consumable materials. Then the second essential part of our atraumatic restorative treatment are the materials. So what are the various materials you require? You require lots and lots of cotton rolls, because it does not require, there's no aerosol or anything. We need to clean off a lot of things in this. So we require cotton roll for isolation. Then you require a dentine conditioner. You require glass ionomers like high strength and high viscosity glass ionomers, either glass ionomers or glass hybrids, and high fluoride. If you're doing a sealant, you require a sealant glass ionomer. Then you require varnish or a Vaseline or a petroleum jelly. Last but not the least, resin coat. which seals up the restoration. So let's go ahead and see what are the various steps of art. Before that, we'll try to understand why GIC was chosen for this kind of therapy. So if you see the ideal requisites of materials which are required for art material, they should have all these requirements. They should be biocompatible, they should be hassle-free in handling, they should be moisture-friendly, they should be a self-curing material, they should form a good bond or good adhesion with both enamel and dentine, they should have good marginal adaptability, they should release fluorides and anti-decay minerals to cause remineralization, they should exhibit excellent durability, and of course a little bit of tooth colored. If it is there, it is well and good and nicely accepted. So taking into all these considerations, a glass enamel was developed called as Fuji 9. As I said, GC developed a glass enamel which was specially for atraumatic restorative therapy. The box itself was called as glass enamel for atraumatic restorative treatment, which followed which was made on the basis of 9 steps of atraumatic restorative therapy. So let's see what are the various steps which are involved in atraumatic therapy, restorative therapy. So I'm going to deal on both art restorations as well as art sealants. I'm going to deal both on art restorations and art sealants. So art restorations has 9 steps, whereas art sealant has only 8 steps. So one of the steps is missing. So we'll start with art restorations. So the first step in art restorations is preparation of art instruments. Now, before we start off with the atraumatic restorative treatment, some things have to be considered, some things have to be taken care. Those are which are very important, and these are the major requirement for the art. That is the patient and operator position. So we need to understand the proper patient and patient position as well as operator position, where you can have a good access, you can have a complete and good access to the patient's mouth, to the cavity in the patient's mouth. You need to position your chair accordingly. There are certain norms which I'm not going to talk about today, but it is available everywhere. So we just have to take care of those positions properly and then move ahead with the procedure. Then second thing which we need to keep in mind is, of course, which is the most important aspect now also, which is the control of cross infection. So all the techniques all the guidelines which have been given to us to control the various cross infections in the clinical practice need to be followed. So that is again the major things which needs to be followed. So if you move ahead to the steps of art restorations, the first step is always is the preparation of the art instruments and the materials before clinical procedure, which means you lay out all your instruments in sequence, properly laid out and in the sequence of use, so that it's easy and the time you spend on the restoring the tooth is minimal. So the chair side time gets reduced if you lay out your instruments in sequence and use it accordingly. Make sure you have enough cotton rolls and cotton pellets. Of course, you can use the suctions because that is advised nowadays to use the suctions. Even for the COVID situations, the high vac section or low vac section, you can go on using it. But make sure you have enough cotton rolls and cotton pellets because that's going to be used a lot during the procedure. The second step of art restoration is the isolation of the operating site. So majorly in this, we isolate it with cotton rolls because this atraumatic therapy was basically designed and devised where you not a lot of expensive equipments and expensive material, the devices are not there. So especially in while you doing our various camps, the community dentistry camps, etc. In those things, these were used. So that's the reason why the cotton rolls play a major important role when you're doing art. So that's why the second step, they maintained that they told that you need to have a lot of cotton rolls. You can go ahead with rubber dam. You can go ahead using rubber dam, but the thing is, generally, if you're not using rubber dam, so ideally we should use rubber dam, but if you're not using rubber dam, you should have a good isolation with cotton rolls at least. So they have to be frequently changed. So you keep a lot of them. So keep a lot of cotton rolls with them. So the third step is examining the cavitated tooth. So as I said, the operator position as well as the patient position is very much important when you're doing this therapy. So make sure you have a good access to the cavitated tooth and start examining it. So when you are examining it, just clean the surface of all the plaque and food debris which is there, because you need to examine the extent of caries. You need to examine how deep the caries is, how big the caries is, whether you have an access to excavate decay or not. So all these needs to be examined properly. So make sure you do that and remove all the plaque with wet cotton wool pellet, and then dry the pellet accordingly. With the dry pellet, just dry the tooth surface. The next step, moving ahead, is once you have examined the cavity, the next step is gaining adequate access to the decayed tooth or the decay. So once you're clear that about the extent of caries, once you're clear that what is the access you're going to get, the first thing, if it is a small access, try using an enamel hatchet or enamel access cutter. These are the two instruments which you can use. You just place it onto the tip onto the instrument. I'll be showing you a video how it is done in further slides. So just turn forward and backward like turning a key in the lock. So it chips off the enamel, which is demineralized, unsupported enamel, and it gives you an entry. So enamel hatchet and enamel access cutter are very important as instruments when you're trying to gain entry. The next step is cavity cleaning. Now, cavity cleaning is majorly done with excavators. So once you gain entry, you start excavating the decay, excavating the soft and infected dentine. Now, depending upon, it has to be done with a proper minimal pressure. Don't put, if the decay is deep, don't put excessive pressure, because there are chances that the small excavator can cause a pulpal opening. So you need to very carefully excavate the decay with circular scooping movements. And if you're going down, if it is deeper, if it is near, it is okay to leave behind a little bit of soft dentine. There's no issues if it is very deep near the pulp, it's okay to leave behind a little bit of soft dentine. There's no danger of leaving an unsupported enamel, because GIC is going to take care of that later on. So you don't have to worry. Then you just take a cotton, dip it in water, clean up all the cavity, and then take a dry cotton and again clean up the cavity and make it dry. So next step after cavity cleaning is conditioning the cavity. So what you use here is a dentine conditioner. It is used for 20 seconds. It's basically 10% of polyacrylic acid. Why do you use a conditioner? Because when you're excavating the decay, there's a lot of smear layer which is inside the cavity, and this smear layer will not allow the bonding of proper bonding of the glass ionomer to the tooth structure. So in order to allow the proper chemical as well as the mechanical adhesion of the glass ionomers, you need to remove that smear layer. So use a dentine conditioner for 20 seconds. Repeat the process of cleaning again. Take a cotton wool, dip it in water, clean it up, and then again, here we are not using any three-way syringe or anything to dry it up. We are just using the cotton. This is what is the major aspect of art. So you take a dry cotton and clean it up. There's no issues. Don't desiccate the dentine. You're not supposed to desiccate the dentine with a three-way syringe or anything. You just have to leave it like that. If you desiccate the dentine, again, the bonding with the glass ionomers will not happen. So the next step is mixing. Now, mixing a glass ionomer is very important. So most of the glass ionomers which were developed for the art technique had higher powder liquid ratio. So it is very difficult. It becomes a bit of difficult when you're mixing powder and liquid of the material which are used for our technique. So if you're using a capsule, that's well and good. There's no issues. There's no problem in the proper mix. But when you're mixing with hand, so proper mix is desired when you're achieving. So the mix should have this shine which is already there. If you can see this shine is there, because if this shine is lost, discard the material, mix a new material, because this shine is the one which is a layer of polyacrylic acid which is going to go and bond with the collagen fibers inside the tooth and form a chemical and mechanical bond. So you need to have this shine. So you need to understand the mixing of glass ionomers also. A proper consistent and correct mix of glass ionomers should be done. Once the mix is done, the next step comes is the restoration of the cavity. So take a PFI, collect the material and start restoring the cavity. So if you're doing it with capsules, you can directly mix the capsules in a capsule mixer and inject the capsules into the cavity. That's as easy as anything. But if you're doing with a hand mixed glass enema, take it in a PFI, pack the GIC well into the cavity, slightly overfill the cavity. In the gloved finger, put some petroleum jelly on your index finger and then press onto this glass ionomer on the top and put pressure so that the material goes inside more. And also you can just spread the material into any of the pits and fissure which are there, which you think needs to be filled. So you can just slide the finger and push those material into those pits and fissure. Then after this, slightly of the excess whichever is there with a spoon excavator. The next step and the last step is finishing of the art restoration. Now finishing of the art restoration, once you have cleared up everything, if there is still, check the bite. If there is still high points, with the blade of the carver, just do the occlusal adjustments. Then later on, apply a little bit of cocoa butter or a petroleum jelly or Fuji varnish. If you want furthermore a good wear resistance to this restoration, apply a resin coat like Equa foot coat and light cure it for 20 seconds. So that can be done. So this finishes your art restoration. What this resin coat does is it gives you a smooth restoration, plus it seals all the margins and it allows the glass ionomer to mature. It allows the glass ionomer to mature inside and achieve a good wear resistance. So resin coat is always advised. So the proper protocol of glass ionomer restorations, that is conditioning with dentine conditioner, then a proper mix, and then a resin coat allows you to have a long-lasting glass ionomer restoration. These are the 9 steps of art which was accepted and provided by WHO as well as the various authors which have worked a lot upon this technique. Then this was about the restorations, art restorations. When you talk about art sealants, so when you go into the sealants, what are the various steps? I told you art sealants have 8 steps. Here, the first thing is always you prepare the art instruments, then you isolate the area, then clean the pits and fissures, etc. You're not supposed to excavate anything here. So the excavation part is not there. So you're just cleaning the pits and fissures and examining the tooth and conditioning the pits and fissures and mixing GIC and providing it to the filling with the sealant. The sealant basically, if you see Fuji 7, it's a pit and fissure sealant. It comes in a pink as well as in white. You just have to mix it and take it up, take a micro brush and spread it across into the into your pits and fissures. If you want, you can light cure it. So it is auto cure as well as light cure. It's a dual cure material. So it provides high fluoride release. Now, if you see GIC, why GIC was so much used when you were during the art therapy in this atraumatic restorative therapy is basically GIC has the ability to control the dental caries as well as to prevent it. So whenever you're whenever you're restoring a tooth with glass ionomer, the bacteria, even if they are there down beneath the glass ionomer restorations, they tend to decrease. They tend to not cause any more activity. So there is no destructive activity which occurs, and slow and steady the bacteria gets ineffective and there is remineralization that starts happening. That's the major reason why glass enamel, and it has got a great bonding to the tooth structure. So it heals the tooth structure. That is the major thing why glass enamel was used, and it was easy to use. So there were three after GC9, the Fugene 9, which was developed for art. Furthermore, modifications of 9 was done called as GL 9 Extra. And then now a new product has been launched by GC called as Gold Hybrid, which is basically an improved version of 9 Extra. Then you have GC Fuji 7, which is for the sealants. So I take this opportunity because I am also from GC. So I did take this opportunity to first time launch a product in a webinar. We haven't launched this product in any of the colleges or any of the webinars yet. So we are just launching this product called as Gold Hybrid. So it's a privilege for me to, because Dr. Nandlal has been so much into this atraumatic restorative therapy. So it gives me a great pride to launch this product on this platform with Dr. Nandlal. So this is a new advanced glass hybrid technology. It is basically a glass ionomer. It is not a compomer. It's basically a more amount. There are two types of fluoroaluminate silicate glass has been included, and a double molecular weight polyacrylic acid has been included. So what it gives the glass ionomer is it gives high acid resistance, good mechanical strength, more tooth-like translucency, more moisture tolerance, and more fluoride. So it becomes an imperative part for your art if you want to do for long-lasting restorations. So that is Gold Hybrid for you. So there is a professor by name Dr. Abhijit Banerjee in King's College London, who heads the minimal intervention dentistry department in King's College London. He has come out with a decision-making flowchart. If you want this flowchart, I can forward you guys the link of this flowchart. So it allows you to make a decision how to go ahead with the various atraumatic therapies in the restoration, various atraumatic restorative therapies, especially during this COVID-19 situations where it is totally, where we have to do aerosol-free dentistry. So he has given a proper decision making on how to go ahead with the permanent teeth and primary teeth depending upon the depth of the cavity. So what are the technique used and how the thing. So this chart, I can share it off later. Then that was about the art. Now I was also talking about something which was which is a recent advance in art, which is called a SMART. So the first SMART was in the last decade. So first modification in art was done last decade in 2000 to 2020, in between, especially in last decade, which is basically to halt decay and seal. Here, this is called a silver modified art, where they use silver diamond fluoride and then glass ionomer to seal it up. So silver diamond fluoride is used to arrest the decay and glass ionomer to seal it up. But one of the major problems with this is there might be multiple appointments required for silver diamond fluoride, which again makes it a bit of cumbersome procedure. So a newer modification came into picture, which is called a simplified and modified, where the capsulated glass ionomers were being used. No silver diamond fluoride, it's just capsulated glass ionomer, which was being used, the GSE capsules. And there is a little bit of modification in the caries removal. In the art, if you see, we have to remove the whole caries, the whole soft decay, but in SMART, you don't need to remove the whole decay. You can leave behind a little bit of partial caries. So here we are using capsules. In art, we use hand-mixed glass ionomers. So if you see the research evidences for this art, so there is not much of difference was seen in the researches between the survival rate between art and amalgam, art and composite. Whereas art has given a lot of healing to the tooth structure, and presently in this situation, the art works out very well. And it becomes the ideal and the safe choice in condition where we have to minimize as much as possible the aerosol production until unless, as much as possible, until unless it is really required, we should not resort to the aerosol producing procedures. So what are why this is The ideal choice is because it is simple, it is minimally invasive, it is effective, it heals the tooth, it preserves the healthy tooth structure, everything is evidence-based, it involves simple and effective infection control policy. Second thing is it does not take up much time. It is less time consuming. So you're spending less chairside time with the art. So I'll just show you one of the videos of the art. So as I told you that how you will do the art restoration. So after doing everything, this is gaining access into the cavity with the enamel hatchet. Then we just excavate out the decay. Here we have used a rubber dam, so it's not necessary as such. Once the decay is removed, we mix glass enema. This is water, then conditioning the cavity, rinse the cavity with air. This is what is to be done repeatedly. So we are not using any previous syringe to clean it up. Mixing of glass enema is desired. Spread the liquid and then mix incremental. I think there is some lag in this, so video. With the PRFM, we just restore it. Take some petroleum jelly on the index finger, and this is the press finger technique. You just press the glass enema into the cavity and spread it across. Starts sculpting. Just carve it off. You take G-Coat Plus or any resin coat. Apply it and light cure. What it does is it gives the glass enema much more strength. It increases the wear resistance of the glass enema. So that was about art. So I would, from my side, if you have any questions, I think you have. There are some questions which are there. So first of all, I would like to thank JSS for giving me this opportunity to talk about simple and smart technique. So JSS is just simple and smart, which is the need of the hour now. We have to keep our practice simple and practice art dentistry. So
yeah, thank you, Dr. Chandramouli. I'm sure there are a lot of questions, but I'd like to just say, of course, the new product which you launched, congratulations.
Thank you, Doc. Thank you, sir.
For that, and I'm sure this the GC the glass enamel was, and now where it is, GC is doing a great thing, I would say, and we never knew that we'll have to now maybe the silver amalgam restoration and the composite, the market share would go down, I would say, and the more of glass enamelers.
Yeah, because, I think we are going back to the basics.
Yeah.
So that is what has been, a lot of, it has been seen that we have forgotten a little bit of basics. So we have to go back to the basics, do what is there for a limited, what we used to do when we used to have limited resources and without any huge equipments and all. And aerota being one of the major part of our dentistry now, because it's lying aside for a while. So at least we have to do certain dentistry where the patient also gains the confidence with this, that he's not also, he comes for the restoration, he has pain and all those things. We can take care with art a bit. So I'll take up some questions. Yeah. So Shiv Kumar has asked me, what is the varnish meant for and what the Equia coat does? So varnish is basically used to be used for conventional glass enamelers in order to Previously when conventional glass enemas were there, we were told that we used to do the finishing after 24 hours. So we need to apply certain varnish or Vaseline so that it doesn't come in contact with the saliva, with the moisture, etc. So for that, the varnish used to be used and the thing. But once 9 and 9 extra came into the picture, so you can finish, because they are all high strength glass, posterior glass enemas. You can finish then and there immediately because it has got a final setting immediate. So, and EQF coat, what it does is it seals the EQF4 coat, that's a resin coat which seals the glass enoma, gives it a shine. Secondly, if at all your glass enoma is not smooth enough, because we are not using any aerators here, so what EQF coat or G Coat Plus does is it gives you a smooth surface and it will not be a plaque retentive areas. Secondly, it also seals the margin. Next question is, does Fuji 7 contains resin? No, Fuji 7 doesn't contain a resin. It's basically a glass enoma per se. So we are curing it in order to hasten the setting of the glass enoma. So any more questions?
Yeah, Dr. Chandramouli, so what you were trying to say is people should not think that glass enoma is very good, it sets in moisture, so they should not miss the step of still applying the coating. That's what you're trying to say.
Yes. Because glass enoma is moisture friendly. But the thing is, excess of moisture is always deteriorating. It causes the surface deterioration and it causes the wearing off of the glass enomas. So it's moisture friendly, but it does not mean that it is totally, you can drench it with water.
No, so still they need to do a protection with either cocoa butter or a varnish.
Yes. Dr. Nirmal has asked me that, can we do art with type 2 GIC? Basically, type 2 GIC is a conventional glass enoma, where you use for art, the special glass enoma which was made was to have a higher strength and higher wear resistance. So the 9 and 9 extra, which was developed specially for atraumatic, has a higher strength and higher wear resistance, and also the glass hybrid which has been launched now. So you need a higher wear resistant material. Type 2 glass enoma is a conventional. It does not have that much of strength now. So it's better to have a higher strength if you're going ahead with a glass enoma, if you want a long lasting glass enoma restoration. Dr. Murli Rao has asked me, glass hybrid, is it a resin modified dual cure option available? Hi, Dr. Murli. I think I know you nicely. So, Dr. Murli, glass hybrid is not a resin modified. Basically, it's what we have done is we have used 2 types of fluoroaluminosilicate glass, 2 different sizes of. That's the reason we call it as hybrid. And secondly, in order to get more, material to be mixed up properly and to achieve good strength, and a high polyacrylic, double molecular weight polyacrylic acid. So it gives you a more substructure of the fluoroaluminosilicate glass particles there. So it gives you much better wear resistance and much better. So there's no dual, it's basically a dual cure only. So if you can cure it, it's also auto cure. Like if you want to hasten the setting, you need to cure it, but ideally you don't have to cure. It's an auto cure material. So similarly, like EQF4, which is available in capsules, this glass hybrid, gold hybrid is in a powder liquid.
So there is one question, Dr. Chandramouli, that is, do you use, instead of doing directly a glass enema as an ART or as a sealant, should we treat them once with a fluoride for some time, for a week, and then go for it? Do you think that would be a good idea?
That will be a good idea, but the thing is, the amount of fluoride which the glass enema restoration is going to provide down is, I think, in pediatric patients it would work out well. I feel because the amount of glass enemas, the amount of fluoride which the varnishes release will provide a good healing ability to the tooth structure. So we can go ahead with that. So if at all we have that much of pediatric, especially the young teeth and young permanent teeth and the pediatric dentitions, the deciduous dentitions. But I think for
no, the point was, would it improve the, the bonding strength? The fluoride would be there.
No, so I haven't heard much about it, like fluoride is going to increase the bond strength or anything, because they have tried doing this silver diamond fluoride. What they do is they do multiple sittings of silver diamond fluoride and then seal it up with glass ionomer. So silver diamond fluoride does not increase the bond strength, but it basically arrests the decay, whatever is there. So that has been tried. But here, see, that kind of silver modified art can be used, but the problem is multiple sittings. So that is a major issue. So because in this COVID situations, we need to have as much minimal sittings as possible, as much minimal chairside time as possible. So that is the major essential in the today's situations. If it's a normal situation, you can try out with the silver modified art. There's no issues on that. But in today's situation, even all the speakers and all the people who are talking about what to do during COVID, what to do in COVID dentistry, are also talking that minimize your chairside time, minimize aerosols, minimize as much as possible the visits. So that is what is being done. Even the root canal, they're saying as much as possible, do it in single sitting or a couple of sittings or anything. I myself am getting a root canal done, and I've got it done in, so tomorrow is my last sitting. So just in 2 sittings, they're finishing off my restoration, the root canal. So avoiding, so that's much better. If it is possible to avoid aerosol as much as possible, it's better to avoid aerosol dentistry for now. So to keep ourselves safe, because what we are also seeing is a lot of dentists are getting affected because of the, even in spite of having so the survey is being conducted, and we are finding out that a lot of practicing dentists, in spite of using PPEs, things are getting affected. So it's better to be safe than sorry. So that's what I feel, because we are also ultimately going back to our house, and our family is there in the house. So we are responsible enough there even.
So would you recommend like how many fillings we can go ahead on a day, a single sitting, using a glass enema? How many fillings would you recommend?
Yeah.
Like,
I didn't get you, Doc. Can you?
How many fillings can they do on a single sitting? How many teeth can be restored? Would you?
I think with glass hybrid, multiple restorations can be done, because it's even 9 extra and glass hybrid, they set immediately. So you don't have to worry about that. The patient doesn't have to eat for 2 hours, 3 hours, or anything. So you can do multiple restorations with that.
Okay.
So one doc, Shivkumar Ramanathan, asked me that SDF doesn't remineralize. No, SDM doesn't remineralize. It arrests the decay. So glass enema generally has the remineralizing ability. So it remineralizes the material.
Sure.
It remineralizes the tooth. So that's the reason why even in silver modified art, it is sealed with glass ionomer, so that it remineralizes the tooth structure.
Okay, Dr. Tamboli, I think we have crossed 10 minutes beyond the time schedule. Everybody will be getting ready to go and do a safe dentistry. I'm sure they will practice more glass enemas, ART.
I think one more question is there, Dr. Nirmal. Yes, gold hybrid is available in India. You can ask any GC representative. He can provide you that. Right? Thank you very much, Doctor.
Yeah. Thank you again on behalf of JSS Academy of Higher Education.
Thanks a lot.
Dr. Chandramouli and GC for making it possible that you could take out time to give us. And I thank all the participants and our team at JSS for making this webinar series from the special research group of quality and safe use of dental materials. And this type of series would continue from JSS, and we look forward all the participants to attend and try to manage and practice safe dentistry. Thank you all.